Good evening. Thank you for joining us this evening. My name is Julie Green. I'm the clinical director here at Tactile Medical, and we are so excited for you to join us tonight. We have a very exciting program. I am going to introduce the two speakers, and then we can get started. So tonight we have with us Dr. Wei Chen. He is a distinguished professor at Cleveland Clinic, renowned for his expertise in reconstructive microsurgery and supermicrosurgery. He has pioneered innovative lymphatic reconstruction procedures such as the octopus, LVA, the freestyle acrobatic LVA, vascularized lymph vessel transplant, advanced LVA techniques for severe lymphedema, and the flying squirrel Matisse lymph-enhancing liposuction. These techniques have consistently delivered outstanding outcomes, establishing themselves as some of the most effective treatments available for lymphedema. More recently, with the discovery of Alzheimer's and Parkinson's disease being lymphedema of the brain, Dr. Chen has expanded his focus to include these previously deemed intractable conditions, providing hopes to a patient population currently with limited options. Also joining us this evening is Carmen Recupero. She is a licensed physical therapy assistant and certified massage therapist with a specialty certification in lymphatic therapy. She has 25 years of experience in leadership roles with hospitals, health systems, long-term care, and startups. She more recently not actually that recently, in 2010, she actually started and created Monarch Continuing Education with one of only 7 nationwide training programs for allied health certifications and has taught hundreds of students in her lymphatic certification courses. She looks forward to continuing development of her programs to educate and train medical professionals in order that they may better help people with lymphatic disorders. So again, we are super excited to have them here tonight to talk about lymphatics of the brain, and we can get started.
Very happy to be here to share the latest updates with all of my therapist colleague. And in this talk, I will explain how everything got started. So I think most of us have been treating extremity lymphedema, arm and leg lymphedema, and some treat truncal lymphedema, even central lymphedema. By the way, that's another frontier. And I will explain to you how we got on the path of treating the brain lymphedema and how this went from being considered something, this hypothesis, when it was initially raised in the surgical world, in the medical world, it was, many said it was ridiculous. And now this is the hottest topic around the world. And it's the pursuit of all major medical centers around the world. So I will share with you how this all got started, where we are as of today, and what's coming next. All right, so I'll give you the conclusion first. The brain lymphatic surgery is now blossoming around the world. And so far, most of the surgeons and physicians are talking about the surgical treatment for Alzheimer's, but rest assured that it's not just the Alzheimer's. Most are talking about Alzheimer's because that's what we shared a few years back. We have to start from somewhere, but we know that it's not just Alzheimer's disease. In fact, there's a whole laundry list of brain's toxic proteinopathies. And it's really a long list, which I will share in the next slide. And also, it's not just the brain. Increasingly, we are finding out so many conditions that are known in modern medicine that were previously never considered lymphatic disorders are actually lymphatic disorders. And tonight we will talk about Alzheimer's and Parkinson's, which were previously never considered lymphatic in origin. So, well, we need to keep our eyes peeled. So this is that list that I was talking about. So these are all the brain lymphatic dysfunctions that are already either proven or are heavily implicated. So just take a look at this list. And this is not even a complete list. And so far, we are already addressing the Alzheimer's and the Parkinson's diseases, and that's already a headline news. And look at the purple. The two purple ones are the ones that we're going to be soon addressing. And that's the post-stroke cognitive impairment. As you can imagine, following stroke, our brain lymphatics are also impacted. And that certainly affect the recovery of function following stroke. And the other is, surprise, autism. Autism has been implicated as a lymphatic disorder of the brain. So this is what's to come. And so all these may be sounding like shocking new discovery, but it's actually not new. We've been observing signs that are pointing us to this direction since 2011. So when I began to treat lymphedema with surgery, and as I said, we were treating initially only arm and leg lymphedema. And what we found was when we treated patients arm and leg lymphedema, so many of them told us that their cognition got better. So we had no idea how this could happen because it just doesn't, we would never consider a surgery that was locally performed in the leg can have an effect on the brain. And so we just by default presume that it's all psychosomatic. They were physically feeling better. They're really happy with their phenomenal surgical results. And of course, then they psychologically feel better. But then we heard this again and again and again. Then patterns started to emerge. We heard a lot about memory being improved, particularly short-term memory. We also heard a lot about attention. And actually, many of particularly primary lymphedema patients, next time when you see a patient with primary lymphedema, ask them, have you been diagnosed with attention deficit disorder? So many of them had attention deficit. And in fact, so many of them were on medication and their attention got better. We also heard a lot about fatigue. And after surgery, they had so much more energy. The brain fog is very common. And these patients would tell us that after the surgery, their brain fog got lifted. And by the way, I think this talk is, I really want to give this talk to all of you because I think the first step, well, as a surgeon, what I have seen is that surgery can help brain's lymphatic dysfunction. But if surgery can help, it's very likely that lymphedema therapy and non-surgical treatment or any maneuvers that also help brain's lymphatic outflow can also help. So that's why I think that I definitely encourage, and I myself am excited to hear Carmen's talk after this. But also I encourage all of you to brainstorm and think of potential treatment that may help this patient population. Well, anyway, going on. So brain fog is a very common complaint, and it's also another very common report that a symptom that got better after surgical treatment. Being able to read better because their memory, their focus, their retention got better. And some patient even has speech problem because they would forget what they want to say, and they also can't recall words they want to use. And this feeling of being uplifted, they feel like they can take on the world, that we also hear a lot in mental clarity. And so all these led us to conclude, after hearing hundreds of patients reporting the same thing, we concluded that lymphatic surgery in arms and legs can impact the cognition. But exactly how this happened, we had no idea. So first piece of the puzzle came in 2014. So yeah, a little bit over 10 years ago. And it was that we found out that our lymphatic surgery, when performed in a part of the body, had systemic effect, meaning the effect extends well beyond the site of the surgery. If the surgery was performed in the left leg, we would see improvement in the left thigh. We would see improvement in patient's abdomen. We would see improvement in the patient's contralateral leg. So that would include lymph node transfer, lymph vessel transfer, LVA, and even liposuction performed to treat lymphedema. The second piece of the puzzle came in 2015 when we confirmed that primary lymphedema is a global systemic lymphatic dysfunction. So there is no such a thing as primary lymphedema of left leg or right leg, or primary lymphedema of the face. Whenever you see a patient with primary lymphedema, it's always global and systemic. If you image their lymphatics in their arm, even though they're only complaining about swelling in one leg, you will find lymphedema in the arm. If you image their central lymphatics, you will find central lymphatic disorder. So that was in 2015. And this means that in primary lymphedema, when we perform surgery in a part of the body, the entire body would improve. So when you combine these two pieces of findings together, that was the conclusion. And that was indeed what we saw. And by taking advantage of these findings, we were successful in treating lymphedema, for example, in the penis by operating in the leg. We're able to treat breast lymphedema by operating in the arm, and we're able to treat lymphedema of one leg by operating in the other leg. So we can not necessarily operate on sensitive area or high risk area. Now, in 2016, we found out that brain had lymphatics, and we didn't discover the brain lymphatics. The discovery was made by, initially, the lymphatics was discovered by Dr. Michael Niedergard in 2012. And that was a fortuitous discovery because Dr. Niedergard's mouse fell asleep. And lymphatics is a system that only gets activated during sleep. So it was really lucky for her, and it's really lucky for mankind. Because of that, we discovered that brain has lymphatics. And Cleveland Clinic's very own Dr. Laveau, 2015, discovered meningeal lymphatics. Well, he wasn't at Cleveland Clinic back then, but he is now. And embarrassingly, I didn't know about their work until 2016. But once we found out about their work, everything clicked. Now we know that primary lymphedema is systemic, and we also know that lymphatic surgery has a systemic effect. And we know that when we operate on these patients, their entire body improved. We also know that so many of them had cognitive impairment. So then it's conceivable that these surgery can help their brain because that's what we saw. And this was Dr. Niedergard's one of her paper back in 2013. She called it the garbage truck of the brain. And this was Antoine's study from back in 2015. So as it turned out, the meningeal lymphatics, so it's lymphatics and meningeal lymphatics. It's a two-part system. So the lymphatics is not actually a true lymphatic system, but the meningeal lymphatics is. And these are our cadaver dissection pictures. So meningeal lymphatics has avoided detection by neurosurgeons and by many other scientists because it's located in this very tricky location. It's sandwiched between, if you look at this second picture right here, between the outer and inner leaflet of the dura, and it runs along the venous sinuses. And it's microscopic. Here you can see, actually, we had the meningeal lymphatics exposed in this picture, but you're not seeing it because it's super tiny. The structures are smaller than even supermicrosurgery, so that's why we're not seeing it. You can only see it right here after staining under the microscope. All right, so it's a two-part system, and to make it easier for you to understand, this is my analogy that you can think of lymphatics as this brush and our brain as the reservoir of a toilet. And so you have junks that develop, algae developed in the reservoir of the toilet, and you use this brush, which is the lymphatics, to brush all the garbage off, and then the garbage gets flushed down the pipe. Think of the pipe as the meningeal lymphatics. It transport all these garbage out, and then the first stop being the cervical lymphatics. And subsequently, the cause and effect relationship between the brain lymphatics, both the lymphatics and the meningeal lymphatics, were confirmed. So neuroscientists selectively knocked out either system, and they were able to reproduce Alzheimer's disease. So now we were ready to put all the pieces together. As I said, primary lymphedema is systemic, and many with primary lymphedema demonstrated cognitive impairment. And so does that is that because their brain lymphatics also were impaired? It's quite possible. And we know that the surgical effect is systemic. This means that many patients that demonstrated cognition improvement following lymphatic reconstruction surgery likely demonstrated so because their brain lymphatics also improved. And the next hypothesis is if the cognition impairment in patients with primary lymphedema is surgically treatable, would other brain lymphatic disorders also be treatable? So based on this, in 2016, we proposed the possibility of treating Alzheimer's disease, which is also, you can think of it as the lymphedema, or, well, at least some of them as lymphedema of the brain. And if you look at how intracranial lymphatics and extracranial lymphatics communicate, they communicate through these two pathways. Uh, for simplicity, we'll just call them the posterior and the anterior pathway. The posterior pathway drained through the jugular foramen directly into the cervical lymphatics. The anterior pathway drained through the orbit, actually through our optic nerve, draining to the periorbital lymphatics, and then draining through the cheeks, and still eventually getting down to the neck. So back in 2016, we proposed that we may be able to treat Alzheimer's lymphedema of the brain by performing LVA in the neck. And by the way, if you know about the surgical world, 2016 was a time when people were still debating whether lymphedema surgery for the arm and leg even worked. And we came out and told everybody, hey, not only that lymphedema surgery work great for the arm and leg, we can also perform lymphatic surgery to treat Alzheimer's disease. And you can imagine people's response. Um, we, of course, failed to publish this. No journal was willing to accept our paper. By the way, the same year, 2016, we also failed to publish the fact that lymphedema is curable with surgery. And by the way, that paper finally came out. If you're interested, you can look this paper up. This was published in its abstract form in 2020, and finally in its full paper, I think it was 2023. So many years after its initial discovery. So lymphedema is curable. In 2019, we found out that we were not alone in thinking about this. This was a paper by Dr. Keaton Patel he's currently at Cedars-Sinai. Back then he was at University of Southern California. Uh, he was able to get this paper published by being more gentle with the language and just simply suggest, hey, there is a possibility that we may be able to do something surgically for Alzheimer's disease. And so he was able to get this paper published. It was a literature review, and he made that gentle suggestion, and he was able to get it published. So we got to work, and this was our animal model, actually provided to us by Antoine, Dr. Louveau. These are transgenic mice that would become predictably demented at 2 months of age. And then we would go in and perform LVA or our newer procedure, lymph node to vein anastomosis, LMVA, to treat demented mice. And so this is what we've been working on. And until 2022, to our surprise, or I guess in a way, it's really that not that much of a surprise, as they always said, bright ideas don't exist in a vacuum. And in 2022, a Chinese surgeon, Dr. Shea from Hangzhou, China, performed successfully in human uh, supermicrosurgery in the neck with a surgical design that's very similar to ours, successfully treating patients with advanced Alzheimer's disease. And now this has been published. If you're interested, you can look it up. There's fairly dramatic improvement, turning patients from nearly vegetative state into walking, talking patients. And since actual human cases have happened, we felt that it was no longer a need to keep our research undercover. So we presented our findings in 2023, same year at AAPS and WSRM. So these are the most prestigious plastic surgery meeting and reconstructive microsurgery meeting. And since then, the genie is out of the bottle, and the race from around the world, all the top centers have begun. So now I will share with you what has been the updates at Cleveland Clinic, what we have done since then, since 2023, and a lot has happened. By the way, in China, since Dr. Shea's announcement and our announcement of our study providing a theoretical basis, a lot has happened in China to date, over 1,000 cases. Um, All right, in the interest of time, I won't play this entire video. Basically, the surgery has become much more commonly performed, and it's no longer just exclusive to Dr. Shea's center. Now there are a total of 8 centers in China performing Alzheimer's surgery, and as of today, over 1,000 cases have been performed in China. In the rest of the world and Europe and in US, especially in US, we probably have the most rigorous, the most strict regulation of all. We don't stand a chance of getting RRB approval for human surgery without more rigorous scientific data. So when we think about how everything got started with these 3 findings, as I have shared with you. Number one, primary lymphedema is systemic. And number two, surgical effects being systemic. And number three, so many of these patients have cognition problems and they were reversed with surgery. So we need to turn them into studies. We need to publish them before we can get to performing Alzheimer's surgery for human. So we finally were able to publish the fact that primary lymphedema is systemic in, well, just last year, 9 years after its initial discovery. Finally, the field had caught on and was becoming more receptive to the idea. And also, again, last year, 10 years after its initial discovery, we finally was able to publish that lymphatic surgery, in this case, liposuction, has systemic effect, that the effect is not limited to the site of the surgery. So what we need to do next is to demonstrate the correlation between primary lymphedema and cognitive impairment and its reversal with surgery. And that's what we have done. By the way, previously we couldn't do so because lymphedema-related cognition problems are usually severe enough that patient will report disabling symptoms, but they're not severe enough to be demonstrable on validated Alzheimer or Parkinson's scales, particularly Alzheimer's. And so during COVID, this brain fog scale, BFS, that was developed to detect and track COVID-related brain fog was incredible. So the BFS, as it turned out, is very sensitive to lymphedema-related cognitive impairments. So this is the study that we have wrapped up, and we currently the study has concluded and has been submitted, and hopefully the paper will come out in the next few months. So we looked into 112 primary lymphedema patient, and we had a control group of 265 patients. And when you look at their BFS score, and broken down into 3 domains, mental fatigue, cognitive acuity and confusion, you can see that patients with primary lymphedema are scoring so much higher, which means that overall they are substantially more impaired in all fronts, in all domains. And so this is very clear-cut, black and white, that there is something going on. And when we break it down further, we see that 32% overall, all of our patients, 32% of them demonstrated cognitive impairment. And our patient had a mean age of 38. And if you compare to the CDC data in patient age over 45, only 11% demonstrate cognitive impairment. So our patients are younger, but they are doing worse cognitively compared to CDC control. And if we adjust our patient and only select those over age 45, then the incidence rose to 41%. This meant that lymphedema patients are 4 times more likely to be cognitively impaired in primary lymphedema. And what's even more exciting is that surgery was capable of reversing cognitive impairment in all of them. Well, not all achieve full reversal, but all achieve either full reversal or significant improvement. And we also looked into the lymphedema cohort. And for this study, we had 79 patients. Interestingly, they are even more affected than primary lymphedema patient. And by the way, I will share with you another finding that our manuscript is still in progress, which is all lymphedema patients have primary lymphedema, and you already know primary lymphedema is global and systemic. Contrary to the common belief that in lymphedema patients, they develop lymphedema at late phase. That's actually not true. All of them already have primary lymphedema, which is proven in every single lymphedema patient. And so this is an interesting finding. 51% of them demonstrate significant cognitive impairment. And this is even higher than in primary lymphedema, and the severity is also worse compared to primary lymphedema patients. And surgery, again, demonstrated successful reversal in 100% of them. So in terms of the surgical design, this was our first generation surgical design, which is to perform LVA in zone 5 in the neck, which is the first lymphatic zone immediately following distal to jugular foramen. And it's got several disadvantages, and probably the most significant of the disadvantages is the potential backflow. When you perform LVA in the arm and leg, if you get a backflow, it's not the end of the world. But in the head and neck region, when we get a backflow, we are very much concerned about intracranial hemorrhage. So that is a potential problem. So since then, we have developed another procedure called lymph node to vein anastomosis. Actually, the procedure was originally created by a Polish surgeon back in the 60s, and this is the revised version. So what you're seeing right here is a lymph node. Let's rewind a little bit. So here we punch a hole in the lymph node. That's a 30 gauge needle, and this is under the microscope, magnified about 27 times. And here is a microscopic vein. It looks pretty big here. And then we sew the vein to the lymph node, the capsulotomy that we have created in the lymph node. And then this lymph node would then start to drain into the vein. So the LMVA, lymph node to vein anastomosis, is considered a lot stronger than LVA because, as you can imagine, a single lymph node drains all the lymph channel in a given lymphosome, which is hundreds of lymph vessels. And if you also count the precollectors and capillaries, then thousands of lymph vessels. And therefore, you can consider one working LMVA being equivalent to many, many LVA. And I won't bore you with all the other technical stuff of how we select a lymph node using ultrasound And so the LMVA was originally developed for growing lymph nodes, but we have successfully expanded the indication to arm lymph node, to behind the knee, and and by the way, when we perform LMVA in the groin, in the arm, and in the knee, we also see improvement in patients' cognition. And we've also introduced the robotics, using the robot to perform the surgery. Here is, again, we're creating a hole, and this portion is still with my hand, and then we bring in the robot to do the connection. Here's the robot doing the connection. Anyway, so with the LMVA came our second generation surgical design, which is to perform LMVA instead of LVA in the neck. But we're still relying on the posterior pathway. And it still has several problems, even though we have resolved the risk of intracranial hemorrhage, but it still has other drawbacks. And with that, we want to resolve the other disadvantages of the second generation surgery. So this brought us to facial LMVA. So we conducted cadaver study and confirmed the anatomic consistency of this preauricular lymph node right here. So if you look at our ear, this is called tragus, this protrusion right here. This lymph node is consistently located just in front of the tragus. In fact, 8 millimeters, consistently 8 millimeters or less in front of the tragus. And it's very superficial. It's not deep under the skin. It's the most superficial structure. It's more superficial to the vein, to the artery, and to the nerve. So this lymph node is very easily accessible. And once we have confirmed that, then that came our third generation surgical design. If you look at this picture right here, this is the anterior pathway, the lymphatic channel, intracranial lymphatics, drain through the lymphatics surrounding the optic nerve, draining to the periorbital lymphatics, and then draining to the preauricular lymph node. The other pathway drained to the submandibular lymph node. Then both lymph nodes then drain to the cervical lymphatics. So this is another pathway. So this is now our current surgical design, and it is our design to treat head and neck lymphedema and also to treat brain lymphedema, including Alzheimer's disease. Here you can see an actual patient. And since the incision that we place to access the lymph node is the same incision that we do for facelift, so the scar would be well concealed. When she healed, you would barely be able to see the scar. All right, so with that, that brings you up to date to where we are now. So we already know that these surgery work. We already know that these surgery works to help patients to reverse their cognitive impairment. So for us, we're not really looking at whether these surgery work or not. We're also not looking at whether these conditions are treatable or not. We know that they are treatable. For us, we want to find out how well does these treatments work and how severe a disease can we treat. And our first objective is we need to get started with our own human trial to actually treat patients with Alzheimer's and Parkinson's disease instead of treating Alzheimer's and Parkinson's disease patients who have head and neck lymphedema. So currently, we can treat those patients if they have head and neck lymphedema. And by the way, as I've mentioned, LVA, LMVA, and liposuction, they all demonstrate patients undergoing these procedures all demonstrate a cognitive impairment improvement. Which procedure would improve the most? Which one is the most efficacious? That study has not been done, and it would be interesting for us to look into it. And also, I just told you when surgery is performed in the leg and the arm, we see improvement in their cognition. Does it make a difference how far the surgery or the intervention is relative to the brain? Is surgery closer to the brain going to work better? Well, it probably will work better. Common sense would suggest that surgery in the face and in the neck being closer to the brain lymphatics may work better, but is that really the case? We don't know yet. Assuming that if distance makes no difference, then we probably don't even need to worry about getting into the brain, which is another arm of our research, performing intracranial lymphatic surgery. However, if getting closer does give us better result, then we do need to work on intracranial lymphatic surgery, and this is where the robot will come in. And also, as I have told you, that we are consistently observing cognitive impairment in patients with primary lymphedema and lymphedema, and we are seeing the reversal following surgery. But are these impairment and improvement secondary to actual cerebral lymphatic dysfunction, or is it related to lymphedema creating toxins, if you will, or systemic mechanisms such as inflammation that indirectly affected the brain and therefore creating the changes that we are observing? That also needs to be investigated. And lastly, we're also investigating additional intracranial, extracranial lymphatic communications in addition to the anterior and posterior pathways, which have always already been identified. And so there are ongoing cadaveric investigations that we are performing on the lymphatics and meningeal lymphatics, and especially the meningeal lymphatics, because meningeal lymphatics, even though it's currently smaller than even supermicrosurgery, but at least it's in a range that's not too far beyond supermicrosurgery. So if we're going to get intracranial, meningeal lymphatics would be the immediate next target. It's not going to be lymphatics. That's all I have. Thank you for your attention.
So thank you, Dr. Chen. Very exciting information to share and exciting things on the horizon for sure. Hopefully we're going to discuss some therapeutic applications of some of this research and how it pertains to therapists and hopefully things that we're already doing in the clinic. So we're talking about the lymphatics generally. As Dr. Chen said, the meningeal lymphatics are the biggest system. There's also these vascular pathways where fluid is dumping in and then moving to the meningeal lymphatics. So very exciting that we've kind of are able to see this happen in our MLD protocols now as well. Just a little background on my excitement. This started in 2017 when I was at University of Virginia. Dr. Jonathan Kipnis and Antoine Laveau were there and sharing research, and we continued to just read their research with vigor. And I presented how this could be relevant in the future for lymphedema therapists in 2019 at the NLN talk, and I was met with some pretty wide-eyed looks. And if you were there, you'll know what I'm talking about. But it was very exciting. I also at the time was working with a research scientist at University of Zurich, and his primary research area was autism and the lymphatics. So I knew I was onto something, and just my endeavor was to create a protocol that we could apply, not the be-all end-all, but something for consistency that we could utilize as therapists with our patients in addition to their upper or lower extremity MLD protocols. But what can we institute to start collecting some case study data? Because right now we have applying protocols and seeing functional outcome measurements change, but it's all case study data and anecdotal reports. Hopefully, with enough therapists collecting this data, let's say you have a post oncology care upper extremity lymphedema patient, and they're also reporting brain fog, and you're doing the brain fog scale and seeing an improvement not just in their upper extremity measurements, but the brain fog. And same thing for so many of our patients that have comorbidities. Maybe they're there for falls and balance and you're doing gait work, but can we, in addition with their postural work, apply a manual therapy protocol and look for outcomes, still gearing toward their functional outcome measurements, what they're doing with ADLs, gait, balance, etc., and look for those cognitive changes with patients with Alzheimer's and Parkinson's. So I've created a class and taught that in 5 cities around the country, and we have therapists applying this protocol and collecting case study data that's very exciting. So before 2017, our lymphatic charts only extended up into these cervical lymph nodes. And now we actually have a visual of the whole lymphatic system of the brain. Very exciting. There's communication between components, and we see this whole meningeal lymphatic system in the brain that's imaged now that we did not have imaged before. Again, very exciting. And we see drainage in these vessels that go to these cervical lymph nodes. So when we're talking about protocols that therapists are using, we're not talking about superficial head, neck, and face work. We do get to some cranial work. And one other exciting thing that I think for a lot of manual therapists that know craniosacral work, I really think this is the missing link to what we have known works for patients and craniosacral work for very severe TBIs, post-concussive, etc. And it's sometimes the only thing that can help with visual disturbance, just headaches that impede quality of life and function. And this tends to be kind of a missing piece. And I think why craniosacral work is so effective is because we're influencing this fluid movement. So when we're looking at lymphatic fluid in the brain, it doesn't have to be as complex as I think we've been led to believe it is. If we think of lymphedema in the body, it's lymph stagnation. So in a limb, we have extra fluid and a protein component. And the longer the fluid is there, the more protein builds up as the pathology of hydrostatic pressure and moving the fluid to the interstitium. And if we have a sluggish system, because the lymphatics are impaired, the water molecule moves out, protein is left behind. Well, the same thing is happening in the brain. We have amyloid beta proteins that are sticky plaques, misfolded proteins that are seen on almost every chronic central nervous system disorder. They're found in Parkinson's, in Alzheimer's, in MS patients, in autism patients, in imaging as early as infancy and early childhood. Also in autism, they're seeing some insufficiency of lymphatic vessels as well. But it's the same thing. These proteins are left behind. And when proteins are left behind, much like in the limb, they cause inflammation, and then in the limb, they cause fibrosis and hardening. In the brain, inflammation that is left behind then is causing the presentation of these many different disorders that Dr. Chen posed. And as he mentioned, there's more than that. But these are hallmark characteristics of central nervous disorders, are that they all have these stagnant proteins. And what we know is responsible for clearing these proteins is the glymphatic system, or our brains, or glial lymphatics, which is our brain's lymphatic system. So I've created a manual therapy protocol that I teach in my class, but that's just one way that we can impact with our patients with what we're already doing in facilitating the lymphatic system. So, our goal, and also, what are we already utilizing in care? Stimulating the deep abdomen, stimulating axillary and inguinal lymph nodes, using pump systems, proximal trunk clearing, like the FlexiTouch pump, the head and neck unit, because a lot of this is not focused right on the face. Actually, we're seeing more benefit from deep abdominal work, sacral work, thoracic duct, central lymphatic congestion. And just like with our limbs, we want to stimulate proximal lymph nodes or accessory lymph nodes if there's been compromise, and pull fluid away from the problem area. So that's what we're doing in the manual therapy protocol too, is a lot of proximal lymphatic, deep lymphatic, and abdominal work to pull fluid and congestion away from the brain. But also we see exciting research, and I think I have about 58 pages of white paper studies for each disorder showing the impact of the lymphatics in relation to cerebral hemorrhage, MS, Parkinson's, autism, long COVID definitely impact, and they find excess amyloid beta protein, Lyme disease. But there are, other factors such as aging, genetics, things that we won't change as much with our brain lymphatics. But we're also seeing huge impacts with sleep-wake cycles. And Dr. Chen hit on the optimal time that the lymphatics are working is when our body is sleeping. So it's opposite of what our limbs are doing. It's most active when our muscles are contracting and our body is moving. So sleep is of extreme importance, and research shows that shift workers, people that get less sleep, certainly have more proteins and congestion and less lymphatic clearing. But also patients that are getting the same hours of sleep, but are maybe sleeping during the day. So if there is a shift in circadian rhythms, that's also affecting the lymphatic clearing. Another huge component that we can keep in mind with our patients are what is their posture like. There are specific studies relating to posture and how we, our patients that are in a forward posture have increased lymphatic congestion. We have so many patients that, sit sleeping up in a recliner or have a forward protective posture after a trach, after breast cancer surgery, and have rounded, stooped posture, and how those things also impact lymphatic clearing in the brain and lymphatics. So how can we mobilize? We know that this is a full body system that includes the brain now, and not just the lymphatics of the limb and central system. A huge connection in the meningeal lymphatics, this pathway out, so to speak, has been that the fluid dips into the perivascular spaces, moves to the meningeal lymphatics, and a huge kind of coup de grace for the system is around the olfactory bulb, and that just behind kind of the ethmoid bone, and is kind of just like we consider the sternoclavicular notch to be kind of the central convergence point before things move to the vena cava. This is kind of central convergence point for the meningeal lymphatics before it starts to go through the deep cervical neck chains. So we've always known for the body that neck work is of primary importance in all of our therapeutic protocols, but even more so for lymphatic work. So we see healthy and impaired meningeal lymphatics and what's happening, both acute and chronic. So we've performed case studies for Alzheimer's, Parkinson's, post-concussive, long COVID, and MS. So both for chronic conditions and more acute conditions such as concussive, and see percentage increases, which I'll show just in a moment. So just like atherosclerosis or like our arteries, our lymphatic vessels can also narrow as a process of aging. So we've talked a lot about disease processes, both chronic and acute, but just the process of aging narrows the lymphatic vessels and also makes them less pliable. So just like a garden hose that's new and bendy versus one that's kind of dry rotted and non-flexible, it's not going to be as sufficient at moving the fluid out. Then if you have a surgery, a trauma, a stroke, MS, something else where proteins are building up, and in addition, a decreased capacity to move this fluid out, then can we assist with what we're already doing, just tweaking and also tracking with functional scales with these patients with the manual therapy protocol, and then hopefully in time also have surgical options for increasing lymphatic flow and aiding in the removal of these proteins to decrease symptoms and increase function. So I'll see what I can get to just quickly and save time for all these wonderful questions. So we have physiological things that we might not be able to change, such as aging and genetics, but there are, can we work with the caregivers on the patient's sleep, their respiration, their body posture, all our other movers of lymph. And then we have our pathophysiologic conditions that contribute. We discussed sleep. So many studies based on the importance of sleep in clearing the lymphatics. But still, even if sleep is perfect, if there's a process allowing the protein to accumulate and the protein being left behind causes the inflammation and then the presentation of disease process, then something else needs to be done. Whether it's a pharmacologic option, we have, physicians doing MRI and sound therapy, penetrating to vibrate and break up plaques, or whether it's therapeutic protocols that we can institute as well. So body posture, can we use postural cueing, yoga, kinesiotaping to increase and facilitate lymphatic flow with very non-invasive things? And this is just showing the cervical neck chains in green as the kind of route out, and our arterial and venous system. So this interstitial fluid that crosses the blood-brain barrier then becomes our cerebrospinal fluid. So it's not different stuff, it's the same stuff. We're just calling it cerebrospinal fluid once it moves over, and we have this interstitial fluid along with the protein. And then we have this interaction with the meningeal lymphatic vessels and the cervical lymph nodes. So we know with Alzheimer's, with Parkinson's, with stroke, there's all autism, long COVID, there's hallmarks of these stagnant proteins being left behind that create the inflammation. So I'll just hit the case studies and then let's have some conversation. So using the protocol I created, we had therapists, and remember, sometimes I don't think as therapists, I have this home health patient, they're bed bound, they're, 600 pounds, and I can't do this and I can't do this, these gold standards. And I say, can you prevent infection and keep their skin intact and keep them out of the hospital? That's a win. It's a win for insurance, it's a win for family, it's a win for the patient. So even though these changes might seem small, you have to remember this is for something that currently the diagnosis only has a decline. There is no positive treatment. The pharmacologic options also cause extension of the disease, exacerbation of the symptoms long-term for short-term gain. So we're talking about something that typically only has a downhill trajectory. So using the neuro-lymphatic protocol, and if they were receiving other therapy, this was the only change, 3 times a week for 4 weeks. Because it's Alzheimer's, you're not going to have patients that will sit still for the whole 60 minutes. That's why there's the variance. And just using functional outcome measurements of gait, cognition, ADL, and general strength. But 85% of the subjects had improvement of at least 50% or more in the test areas. And those improvements were generally about 25% or better. So this is very gross. It's not a funded university research study, but if we have enough therapists applying specific techniques and showing improvement, then hopefully we can get more research centers that will fund studies to get this data and get a support for MLD to be widely recognized and reimbursed specifically for cognitive disorders. Last slide. We had 6 subjects with the neuro-lymphatic protocol 3 times a week for 4 weeks, 60 minutes a length. And here we did strength, Berg balance, ADL and FOM scores, and then a dynamic gait, since that was more of the deficit in the Parkinson's population. Only 75% of the patients had a change, but that was 25% or more increase in about half of their skill categories. So for this to be non-pharmaceutical and non-invasive with no risk of infection, meningitis, etc., I think this is positive. And again, it's preliminary, but I think it's positive, and I think it shows what we have seen as therapists, but not known exactly why we're having these cognitive or central nervous system positive outcomes with our manual work. So thank you, and I'll leave some time now for questions, and I'll let Julie facilitate that.
Thank you both so much. This was fantastic. I've been waiting for this, and I've been so excited about it because I've been interested in this for several years. One person brought up the topic of Dr. Bruno Chickley, and I had in the past taken many of his courses, and for years and years ago, he had really talked about brain fog and the ability of MLD to make improvements on that. So wanted to give him a little bit of credit. So I kind of summarized some of the questions, and one of the things I wanted to ask Dr. Chen is, I heard you say something about if you're doing one of your liposuction procedures on, for example, a limb, that you're going to see some systemic improvement. Can you just give me a little bit of detail about that? Can you expand on that a little? Are you referring to additional reductions or?
So, by the way, as I mentioned in my talk, the effect is not limited just to liposuction. And it's actually a little bit surprising that it happened with liposuction also. The effect was initially observed with lymph node transplant, and that was our original procedure. So we found out that patient with symptoms in multiple parts of the body, when you perform surgery to a part of the body, the entire body improved. So we see this universally in all primary lymphedema patients. We also see them in patients with secondary lymphedema, although with secondary lymphedema patient, most commonly you only have patient having a single part of the body being symptomatic. Multi-part symptoms are more commonly seen in patients with primary lymphedema. And by the way, so frequently I see providers mistakenly think that primary lymphedema is limited to a part of the body because that's the only part of the body having swelling. But when we image the patient's lymphatics system, whichever part of the body we image, whether it's the other arm, the other leg, their torso, their face, even internal central lymphatics, we found problems. And that goes for every single primary lymphedema patient. Now, as I said, this systemic improvement happens to all lymphedema procedure. So that applies to lymph node transplant, lymph vessel transplant, LVA, LMVA, and liposuction. It was more surprising to us when we saw that this happened with liposuction also because liposuction is a mechanical procedure that removes tissue. And in fact, many are, including surgeons, mistakenly think that using common sense that liposuction is a trade-off. It removes bad tissues, but at the same time, it causes lymphatic injury, which is actually not true. And on that, we have published. Our study finally came out. Following proper lymphatic liposuction, every single patient, 100% of the time, demonstrated lymphatic improvement in lymphatic function. And this improvement extends to the rest of the body. So our conclusion is that the lymphatic system has such a robust interconnectedness. So when we worsen, it seems like not only a part of the body worsen, the entire body worsen. And when we get better, it seems like the entire body gets better.
Yes, absolutely. And we do know that as it relates to manual lymph drainage too. We do see a systemic effect. And I think that answered a couple of the other questions in the Q&A about, because you mentioned primary lymphedema quite a bit, to secondary lymphedema, that it is similarly going to result in a positive benefit. throughout. Some of the other questions were around some other disease states, which were migraines, autoimmune diseases such as lupus and things like that. So do either one of you have any comments on that?
I have seen studies on migraines, also interestingly, specifically on glaucoma and glaucoma pressures with lymphatic impairment. I haven't seen anything on lupus or autoimmune specifically, other than there's inflammation present, inflammation. So I think there's an inflammation hallmark in both cases. But I haven't seen anything directly on lupus, but I haven't looked for it either.
Okay,
So
thank
I
you.
think we need to be discerning. I mean, some of the conditions mentioned, for example, migraine is multifactorial. That there's multiple types of migraine, so they're not all the same. For example, some of the migraine are related to direct nerve compression, and therefore some of the migraines can be surgically treated by nerve release. So not all migraines are the same, and we know that when intracranial pressure goes up, we can have headache. So some of the migraine conceivably may be related to brain's lymphatic system, and I'm saying maybe just because based on our understanding about it, it's not too far-fetched to think that there may be parts of it. And just like when we're talking about these brain disorders, we're not saying that we can treat, and we shouldn't be saying that we can treat all Alzheimer's disease. There are certainly multiple forms of Alzheimer's disease. And so I think as we approach and move forward, we need to be very cautious and really don't overstate and don't overclaim, because these are already claims that are wild, that are quite difficult for mainstream practitioners to accept. It's very easy to get discredited. So we definitely don't want to overstate. We want to state, and we need to be grounded with evidence. And so there are a lot of work that are being done around the world right now with multidisciplinary approach. After all, we are surgeons. We Many of these brain disorders, neurology is not our area of expertise. So when it comes to diagnoses, when it comes to outcome tracking, outcome evaluation, we're leaving it up to our neurologist. And yeah.
Okay, thank you. Thank you for that. I have a question around the progression of lymphedema in general and in related to the brain. Are you aware, or maybe you mentioned it, but are there any studies that show with the progression of lymphedema untreated, is that also having a progression of the cognitive impairment?
So I can tell you there is no study, but um, that is a hypothesis we want to be very careful about making, because you can imagine the fear that will generate in all patients with
Sure.
primary lymphedema. We're not going to start to say that if you have primary lymphedema, you're predisposed to brain problems. So yes, based on what we know so far about the lymphatics, about the brain's lymphatics, about the systemic effect, about the systemic involvement, it is certainly possible. But until we have demonstrated that correlation, that we see more Alzheimer's disease in patients with primary lymphedema, we're not ready to make that claim. And that is a uh, serious assertion with a lot of implications.
Carmen, do you have any comments or anything? No?
Nothing additional, no.
Okay. There's quite a few questions from the therapy group here that is interested in the brain fog measure. Is that something that you can share, or is that something,
Oh,
can
yes.
you share where that's on?
The study is freely searchable. If you do Google Scholar, search for brain fog scale, it came out, I think it was 2022 or 2022. Of course, I'm happy to. By the way, we're working with the Polish researcher to come up with an updated scale, but the old scale is already available from her original publication. If you search for that, you'll find it, PubMed or Google Scholar.
Okay. And I do want to bring up, since we are tactile and sell the FlexiTouch product, the fact that you both pretty much touched on the fact that, you know, there is a place perhaps for some improvement with the utilization of pneumatic compression, just as there is for MLD. When you talked about some of the locations that Dr. Chen, the tragus, now, do you see a benefit using the FlexiTouch in that area?
So I certainly can't hypothesize that there may be a benefit. Um, I think the logical sequence, yes, I always encourage industry, especially the industry with influence and well-funded industry, to get into the field, because with your involvement, things advance faster. But the question is whether pneumatic compression on these nodes will help with the lymph drainage at the brain. I think certainly possible, but it has not been investigated. Those investigations will need to be done. And so to start, you need to ask, is compression at these nodes, pushing on the nodes, is that going to enhance the drainage? Maybe, maybe not. So we need to look into it. And so I certainly have heard and lots of reports from lymphedema therapists, definitely resonating with what Carmen has said. And as I said, currently what's lacking is a proper formal evaluation. And that's what we are currently doing. We're definitely happy to help any of the therapists in the audience. And Carmen, also, if you're interested in collaborating, we may have resources that may be able to assist you in getting your results demonstrated scientifically with technology, and in turning them into publishable data. And that definitely would then become usable, validated information in the medical literature, and that people can resort to. And if MLD is proven, well, MLD and or surgery being proven to be helpful in treating these brain disorders, then the next is to develop devices, including, for example, the pneumatic compression. What else can be done?
Right.
What devices can we come up that will help patient? Pneumatic compression being patient-driven, patient-operated, not dependent on a therapist or a surgeon. They can do that treatment at home. Definitely worthwhile to look into in a sequential, logical sequence. Yeah.
Carmen, do you have anything to add or no?
Yeah, that's absolutely the goal, is to track data on MLD protocols that they're performing. You know, ideally it would be the same protocol so that it'll be consistent what manual techniques are being used, collecting case study data, you know, poster presentations with NLN or any conferences, start getting data collection so that we're compiling data from all therapists that are implementing the protocol, hopefully to get enough to get the validated studies complete. That's certainly the goal.
Great, thank you. I think this question is for you, Dr. Chen. With protein buildup being a primary cause of VP shunt malfunction, is it possible that some of these procedures can be performed in conjunction with a currently placed shunt to improve safety for hydrocephalus patients?
So actually, normotensive hydrocephalus is one of the conditions that are quite promising being treatable with these procedures. In fact, there's already a case report published by Professor Mingwei Chang out of Chang'an Memorial Hospital in Taiwan, using lymph node transplant to treat normotensive hydrocephalus. which is a procedure that we no longer perform because we have completely replaced lymph node transfer. In fact, with 2 generations of procedures, initially with lymph vessel transplant and subsequently with LVA. And currently, our LVA is on the verge of being replaced by LNVA. But if you're interested, the procedure was performed by creating a burr hole in the skull. So drilling a hole in the skull so CSF can come out. And Professor Chang performed lymph node transplant, placing a lymph node flap directly over that opening in the skull. And the flap then supposedly absorbed all the excess CSF and then transported the CSF into the venous circulation. So the patient in his series were able to discontinue their VP shunt.
Okay.
But
Thank you.
that
So there is one, oh, sorry. There's one more for you, Dr. Chen, and then there's some more about Carmen and her protocol and her courses. As a surgeon, have you seen more consideration of the effects of surgical treatment or cyberknife treatment for brain tumors on neurolymphatics?
cyber-knife on neuro-lymphatics. I haven't heard anything related to that.
Okay. All
I
right.
do see a question that I want to address. I think this is
Yes.
highly important. And so, by the way, the terminology related, there's a question related to our use of primary lymphedema. So I think the terminology surrounding primary lymphedema is quite chaotic. And the question asks whether I'm describing hereditary lymphedema. So when we say primary lymphedema, we meant anything that patients were born with. These were not acquired lymphedema. They may not be symptomatic at birth. In fact, they may be asymptomatic most of their life. We've seen it's not uncommon that we see patients with primary lymphedema becoming symptomatic in their 70s or even 80s. When we see a patient with primary lymphedema, when we discuss with a colleague, so frequently their knee-jerk response is, "Did you get a genetic study?" So I can tell you that primary lymphedema is uncommonly hereditary. Even though most people ask about genetic study, primary lymphedema is uncommonly hereditary. Probably so. Every week we see about, I would say around 20 primary lymphedema patients. We treat way more primary lymphedema patient than secondary. Why primary lymphedema patient all came to us, I don't know. But probably we see one primary lymphedema patient with genetic pattern, hereditary pattern, probably 1 out of 30 or 40 patients. So very uncommon. Majority of the patient with primary lymphedema are sporadic. No one in the family has it. They just, for whatever reason, develop primary lymphedema. So I would recommend discarding the system that term primary lymphedema precox, congenita, and tarda because they really mean not a whole lot. They have no diagnostic meaning. They have no treatment implication, and they have no prognostic values. Let me take the last one back. They have slight prognostic value in the sense that the age of onset of symptoms in primary lymphedema tend to correlate in general to the severity of underdevelopment or hypoplasia, which means that if you have a patient who became symptomatic in her 70s and 80s, that patient only had very mild lymphatic hypoplasia. And the other end of the extreme would be those who were born swollen, those swollen babies. They have the most severe hypoplasia and therefore are the most challenging to treat.
Thank you for going into that explanation on that. I haven't heard that before, so be interested to hear how other people feel about it. There are quite a few questions for Carmen, but I think that those questions can certainly be answered via email. She generously offered to answer them and then send them to us, and we can distribute them to the attendees. More about her course and about some of her protocols and how she's treating these patients. And I think we should end there. We're at 15 minutes after the hour. I do want to thank both of you so much again. This has been very, very informative and really exciting to just see the traction that is happening in this space.
It's great to have the interest, and thanks for everybody attending to just have interest, and that's what will get the support and funding for research studies.
Absolutely. Okay, well, thank you so much. I hope everyone has a great evening, and we really appreciate your attendance.
Okay, thank you. Bye-bye.
Thank you. Bye-bye.